Nigeria is a vast country with a population of almost 70 million people, the largest population in Africa. The great majority of the people live in the rural areas. The country has vast resources, including oil, and Lagos, the capital city, depicts this wealth and the effects of a rapid technological advance. Lagos has got a teaching hospital, maternity hospital, children's hospital, and many other health facilities. But has it made any improvement in the people's health? Can they get the health care they need when they need it? In my work, I see our children dying every day. Well, did she come in with that? She came in with that. She got polio too? At first, when you're first in the area of pediatrics, you think you're doing something good. But after a few years in the profession, you discover that you're seeing the same problems year after year, and you keep on wondering, when will it end? I have been head of pediatrics, Lagos University Teaching Hospital since 1967. And I have been in pediatrics now since 1956, so that I have a pretty good idea about the problems that cause death and ill health among children. Now, when I went into pediatrics, it was my intention at that time to do all I can to reduce mortality and morbidity. And in those days, the only way we knew to do this was by studying pediatrics and join the Department of Pediatrics and begin to treat children who are ill. In those days also, community care has not advanced into the stage in which we know it now. But over the years, it became clear to me that most of the diseases I was called upon to treat every day were preventable diseases. And in many cases, as with this child who is severely malnourished, by the time they came into hospital, it was too late. For every child in the hospital, there are hundreds in the community with the same illness. It therefore became clear to me that the only way to tackle this problem is to shift one's emphasis away from curative pediatrics to preventive pediatrics. Moreover, one had to go to where the diseases actually began, in the community, so as to tackle the problem. Nigeria has one of the highest death rates in the world. 75% of all deaths in the country are in mothers and in children under the age of 5. In some parts of Nigeria, half the children born never reach their 5th birthday. 90% of deaths in children occur from conditions such as fever, convulsions, diarrhea and vomiting, bronchopneumonia, measles, anemia, and malnutrition. You will notice that all these diseases or disabilities are either preventable or easily cured when treated early, or both. In mothers, the majority of deaths are related to pregnancy and childbearing. So a great emphasis for the planning and the delivery of health care must be on these high-risk groups. There are various attempts in Nigeria now to find solutions in providing basic health care, even in the most rural areas, even under our present conditions. We will go first to the east, that is the Cross River State, to the area of Itigiti. Here is a community involved in providing its own health services. In the village of Odadama, the women of the church guild have gathered on a Saturday to join in the building of a village health clinic using their local resources and manpower. In the past, resources within the community have been ignored. The government will build a clinic, someone will be posted to it, and the community was supposed to come to it for help when needed. But those clinics, as we all know, have been very hard to staff and maintain. The community itself had not been involved in establishing the clinic. Here at Adadama, the process has been reversed. The health program has gone first to the community and involved them in providing their health care. This clinic, in fact, will also be staffed by people trained from within the community. How did this all start? We are going to show you a system for delivering health care set up by dedicated Nigerians who had been concerned for a long time with the low level of services in their own part of the world. This is Dr. Imoke and his wife, who is a nurse. As medical practitioners trained in the orthodox manner, that is, to provide mainly curative services, they naturally began by establishing a hospital in Itigidi. But as they continued to grapple with the problem, they discovered that they had to do two things. First, because of a shortage of trained health personnel, they began to train local people for specific skills. Secondly, they discovered they had to go out from the hospital to bring the services directly to the surrounding villages.
As a child, I lived here. I was born and bred here. I went to Umuahia Government College. And from there, I went on to what used to be known as the Yaba Higher College. And it was there that I did my medicine in the medical school in Lagos. And while I was a student of medicine, I used to come home almost every year during the holidays. And whenever I came home, I would be confronted with cases that could easily have been cured if there were a hospital nearby. Children would die of diarrhea or pneumonia or malaria. Adults would die of maybe strangulated hernia. And women would die of difficult labor and so on. And because of that experience, I made up my mind while I was still studying medicine. I resolved that if I ever qualified, I would start a cottage hospital in this place.
Hello. How will you? Adia. How will you? Working.
Fortunately, I met my wife in Kano, where I was medical officer in the city hospital there. She was doing her nursing. I found that she is really an asset because she is so very much interested in nursing. After getting married to me and after having 3 children, she had to go to Ibadan University to finish up her nursing course. And from there went to England to do a midwifery course. So she's a qualified midwife and general nurse. And she's so devoted to her work that I feel most of the credit in this hospital should go to her.
We find that the hospital started growing in the first place, but unfortunately we couldn't get the trained staff. So we started by feeling that probably these young girls, who probably would have been good nurses if they had the good educational qualification, if we trained them to perform some of the nursing duties, they might be able to. So that was how we started.
You see, the area I'm starting to clean. Not just where the doctor is going to operate, but every area near to the place where the doctor is going to operate.
We'll give them just short-time training. Some of them are really good. You can find what they can do immediately, and you can post them to a particular spot. They are all anxious to do something. The more responsibility you give them in the nursing field, the happier they are. It's there. Okay, listen to the photograph then. Take a place like Adadama. If you want to cover Adadama, you need at least 12 community midwives. Now, we cannot even get one now. And if we have to wait to be able to produce that before we can give health care to the people in Adadama, you can imagine how many people will die. So we train these young girls and young boys. They can work in these clinics, work in the hospitals, prevent what I think I would call what should cause death. For instance, convulsions, malaria, ordinary malaria can lead to death. But if it's well handled, if these girls can do it, why not?
Actually, when I had thought of this hospital, I didn't know it was going to expand. I thought it was something I could manage with maybe one other doctor. So I sponsored my cousin, Dr. Koma, to go and train in Scotland. And I thought the two of us could manage the hospital.
I feel very happy about the fact that we have been able to train non-medical people to do as much medical work as possible. The girls I'm operating with are all auxiliaries. They can read and write, and that's all. We identify skills that are needed for specific areas of work until they get to know and it becomes a part of them. Then it comes to the actual operations, and they are taught the various stages of the operation and the instruments used. All this appears so long, but after about 6 months of continual teaching, you could get somebody to start learning to assist you in operations. In any case, this is a mechanical thing. You don't have to be extremely brilliant to get a forceps and apply on a bleeding artery.
Mary was actually trained here in the hospital. And when it became necessary to send somebody to Ekureko, of course we have no trained staff, as I told you, we had to send Mary. And we found in her the quality of a leader. And she's doing all the deliveries, and she's very good because she comes to say, now I had this problem last night. I did this, but I don't actually know if I did the correct thing. You advise her, and then you teach her. That's what I mean by on-the-job training.
You know, in the clinics, the drugs we give them are the sort of drugs that any household person would have, anti-malarials, anti-diarrheals, etc. And all they do is to teach people the right time to use these things. I grew up here, but I wasn't a big boy when I moved on to Calabar. Now, in the old days, there were no roads connecting Itigidi with anywhere. The only means of transport was by river. From Calabar, you came up by canoe about 3 days. And then the launch came up every week with mails and went on to Ikom and to the Mamfe, which is in the Cameroons. And that was our contact with the outside world. Well, when I say the old days, I mean about 20 years ago, when I was a young medical officer. Well, then, you see, one, we hadn't enough personnel. And one hadn't even enough time to work in his hospital, how much more the government dispensaries. And so the government dispensaries were not visited regularly. There was no good program linking the dispensaries with the hospitals, the dispensaries with the villages and the families. I think that linkage is what we have now been able to try to do. The linkage between the hospital and the dispensary wasn't very good. The linkage between the dispensary and the family was not existent. really. The people had to trek for miles to come to the dispensary. And most of them didn't bother. But now that the dispensaries or the health centers go out to the people, I think that is where the difference really lies.
I think there are very few hospitals that are doing what we are doing in this place. That is opening child welfare clinics in all the villages around, and making sure that we visit them and treat patients there regularly. I mean, you can hardly see this sort of thing in other hospitals. The staff there is mainly glued down to the hospital. They don't go out to reach the patients. I think this is the main thing that I feel very proud of.
The result is that we are expanding in our work every day. It is a pity because it's really a heavy load for us right now. But we are managing, and we have that satisfaction of being able to help the people. It's what I would say is the best aim.
The child suddenly developed convulsions, which was probably due to very high fever. And we had to rush him, not minding the tables, the registration, and so on, to give something, to stop the twitching. And then I wiped the body, and I gave aspirin to bring down the temperature. And we've given treatment already for malaria.
A life-threatening condition has just been treated very simply within the community. This kind of treatment is carried out by health workers who are regularly present in the community, and this technique is also taught to mothers, which can be applied in similar situations. We have shown you a health service using lesser trained health personnel that moved from the hospital out to become community-based. Now we're going to look at a service which is almost wholly community-based. It was begun by the Church of the Brethren in the northeast, in the rural area around Gakida. In this area, 90% of the population live in small villages of between 200 and 500 people, served mainly by footpaths and hidden in the countryside. Gakida, one of the larger villages, serves as the training center for the program, in which 55 villages now participate. These health workers, who were selected by their communities, have come for a 3-month course which uses song, dance, and role-playing in the training program. Leading the group is Moses Fliza, a rural health superintendent who is in charge of the training. The song which you are now hearing is about schistosomiasis. For this training, 1 male and 1 female worker are selected by each village. The cost of the training, provision of the service, and the building of the health posts are all borne almost entirely by the village communities in accordance with a contract signed with the program. Yatama Tafa is director of the service. Here he is dancing in front of Moses Fliza. It is Yautama who makes the first contact with the villages, inviting them to join the program.
This project, in fact, is built on community development principles. We try to get the villages to try to think out ways which they would actually help themselves. We don't say we have bring health project or healthcare to you people. No, that's not the method.
He first approaches the village chief. If the chief is interested, Yautama asks him to bring together the people respected in the village. Religious leaders, the Muslims, the Christian and the traditional, the school headmaster, ward heads, and so forth. A series of meetings are held, culminating in a formal contract specifying the contributions of the village on the one hand and the health program on the other.
We start with asking questions like, what are your health problems? You know, these people will name different kind of signs and symptoms of diseases, not normally name the disease because obvious, some of them don't know what causes blood in urine or so they don't go into the medical terminology. We allow them to express, themselves much, and then we ask them, all right, would you like to get rid of these problems? And then we go on with, if they would be willing to get rid of that kind of problems, all right, then they need to form a committee which would be responsible of getting rid of such problems. Then we go on to say, well, if you're willing to really know how you could get rid of this problem, it's no good for someone come outside, to come and help do that for you. Why don't you do it yourself? And if you want to do it yourself, well, the easiest thing to do is to get people from the community, to be able to do that. We will help train those people for you, but then would you be able to get those kind of people?
Is it a chair?
No,
No, it is not.
No, it is not.
What is it?
It is it.
It is a table.
It is a table.
All right, next paragraph. Paragraph 2, sentence 1. Yes, Kubuli?
Graba is a village that is having about 500 population. Well, they have just got a new school. I mean, they haven't got school before, but now they have a new school with 2 classes, class 1 and 2.
It is a hen.
All right, what is it, class?
It is a hen.
Well, these people, in fact, have no modern medical care until when this rural health post built into their village through communal effort. These people in Graba farm guinea corn, groundnuts, and few cocoyam. But some of the crops cannot grow easily there because Graba is such a rocky place. The health workers are part-time workers, since the village is not populated. They can't give the health workers full-time work. The woman is called Rahila. She has her farm that she works on during the time that she is off work from the health post. While Samuel, he is a hard-working fellow. He has been on the work for 2 years. This is his 2nd year.
We don't want these people to be moving about, getting this training and go and leave the village to go and take appointments in other areas. So there are first permanent people married. And secondly, there are people who can read and write in Hausa, which is the most common language used in this part of Nigeria. And then there are people who are willing to contribute to the development of their communities, who are willing to help the community without being paid for it very much. When these people come to the school, it is a 3-month course. So on their arrival, we go straight on our subjects by stories. We take every disease. We start with malaria and bilharziasis, so we go on. It is believed that people learn faster by stories because in our tradition, our old people at home, tell stories to their children to teach moral instructions. We teach people here through stories which relate to how one gets certain diseases into his body and what will be the signs and symptoms of these diseases and where this person can go and get curative care. And then within the story, the preventive measures that is to be taken by the persons infected with the disease in the story. The first play is a drama about a boy who gets tuberculosis. In the first place, this boy, by name Musa in the story, left his father's compound when he was 18 years old. And he went to the city. In the city, he met his friends. And his friends stayed in a small round hut without a window. Sometimes, one of those people started coughing and was losing weight, getting thin and weak. And when he was coughing up blood and he disturbed their sleep, they decided one morning to take him to the hospital. Musa stayed in the city for 1 year. So he told his friends that he is now going back to his parents because he requested to come and stay for only 3 months. And when he was coming home, he bought some presents for his father and his mother. So on his coming home, he was welcomed by his parents. They slaughtered chicken for him, and he was enjoying the food at home. And he was working very healthy, very well. But 6 months later, he started losing weight. He was having fever in the evening. Then he started coughing, and he was getting thinner and thinner. And finally, he started coughing up blood. His parents decided to take him to a traditional healer who will help them. When they went to the traditional healer, he said that he knew what was wrong with that boy, and that is an easy thing for him to cure. He received some money from them, and then he gave them the treatment. When they came home, the boy did not improve. Instead, he was getting worse. So they went to the village health worker in his health post for treatment. And when they went there, the village health worker told them that this boy is having a tuberculosis after examining him. The village health worker told them that you get this disease by staying close to a person who is having it. And if you eat and drink on the same tissue with him, or if he coughs and spits on the ground, it can be flown into the air. The village health worker advised them on how to take care of this boy's sputum and special diet for this boy, saying something like groundnuts and beans, and meat and fish, and fruits, leaves that this boy should eat, and advised them for treatment. That is the end of the play.
This is the health post in the village of Giraba, built and paid for by the community. Samuel works there in the mornings. He is available to the community on a daily basis. When he is at work, he is able to check for conditions such as anemia and malnutrition, which undermine the health of the children and increase their susceptibility to diseases. He provides simple curative services using standing orders, which state his limitations and the stage at which a case should be referred to a dispensary from where his work is supervised. Rahila, who is at the same health post, sees all the pregnant mothers and supervises their delivery.